Okay,
Thank you.
our final speaker of the evening is Dr. Sonia Anand. She's professor of medicine in Hamilton. She's also director of the Population Genomics Program, and she is a clinical scientist. Her research interests includes environmental and genetic determinants of vascular disease in populations of varying ancestral origin and women in cardiovascular disease. She has many accolades. She's published on many trials. I'm sure we're going to hear about one of the most recent ones right now. So we are really honored to have you with us tonight, Sonia. So thank you for joining us.
Thank you for the invitation, Jeff, and to David and everybody else. And I'm going to speak about peripheral artery disease, which may be quite different from what you have heard this evening, but it's a very important area because patients with PAD typically are underdiagnosed and undertreated. And for many years, we didn't have very much to offer them from an antithrombotic perspective. But the past 3 years have really led to some major changes based on some clinical trials that we have done, and I've been involved in 2 of them, and I'll share that with you tonight. And these are some of my disclosures and conflicts of interest and mitigating potential bias, and the overview. So I will start this evening by presenting a little bit about peripheral artery disease for those of you who may not have had formal training or do not see patients on a regular basis with PAD, and then come to guidelines in terms of directing our best management for PAD, and then come to some of our recent clinical trials testing a combination of antiplatelets plus low-dose anticoagulants. So there we go. So if we think about patients with PAD, essentially they have widespread atherosclerosis, typically affecting the limbs. And at present time, there are over 200 million patients worldwide with PAD and over 12 million Americans. We don't have as good data in Canada, but we expect that with the increase in type 2 diabetes and a relatively stable percentage of the population who smoke, that as life expectancy increases in high-income countries, the burden of PAD is expected to increase along with it. So it's a growing problem. Patients with PAD have a high risk of suffering major adverse cardiac events such as MI or stroke or death from those conditions, as well as major adverse limb events known as MALE. And those are things such as acute limb ischemia, sometimes going on to major vascular amputation. Now, the risk factors for PAD, number 1 risk factor is smoking, number 2 risk factor is diabetes, and when present together, that they have a multiplicative risk increase on PAD development. The other traditional risk factors for cardiovascular disease are also risk factors for PAD, but it's really smoking and diabetes that should lead you to think perhaps a patient who complains of leg discomfort with walking merits testing. Now, when we have conducted trials, we have the ability to look at patients based on their history of vascular disease. And these are data from the COMPASS trial, just looking at the incidence of things such as major adverse cardiovascular events. And you can see over about a 3-year period, patients who have only CAD or only PAD have about the same incidence risk, around 6%. However, when CAD and PAD are present together, the risk is greater and it's above 10% incidence risk. So this type of patient is often labeled a polyvascular patient, a patient with vascular disease in more than one arterial bed. And those patients have the highest risk of all vascular patients, and therefore we should be as aggressive as we can with medical therapy. I show this to kind of make a parallel between the way we think about stable angina and its stages progressing to unstable angina or to ST elevation MI. And people in cardiovascular disease are always trying to think, how can we prevent STEMI? The mortality risk of a STEMI is about 8% after 1 year. If we make the parallel with PAD, claudication could be considered equivalent to the initial diagnosis of angina. Patients with PAD may progress to require elective peripheral revascularization, or even further to develop critical limb ischemia. That may be things like a rest pain or night pain or a non-healing ulcer. Or they may develop the most severe complication, which is presenting with acute limb ischemia, a cold, painful, pulseless leg, often with paresthesias. And patients with acute limb ischemia have a 1 year mortality of 12%, just making the point that that's greater than a STEMI 1 year mortality, and have a high risk of amputation at 1 year, close to 30%. So these patients with acute limb ischemia are extraordinarily high risk, and any therapy we have that can prevent acute limb ischemia will certainly improve the prognosis for our PAD patients. Now, if we look here at patients who have, just my screen's freezing a little bit, patients who require a major vascular amputation, I put this slide up to show that their survival is equivalent to someone with stage 4 metastatic cancer. So again, just like any therapy we have to prevent acute limb ischemia, same goes for preventing a major vascular amputation. Once something like a major vascular amputation occurs, the patient has a very high mortality thereafter. When we look at guidelines and how guidelines direct how we manage patients with PAD, the most recent set come from the European Society of Cardiology in about 2017. I will say we are updating the Canadian guidelines, and they should be out by 2021. And if we look at this bottom box, you can see the foundational treatments for patients with PAD are to get patients into a smoking cessation program, also to improve leg claudication walking programs, and then the usual cardiovascular medications to reduce coronary disease also apply here in PAD. Lipid lowering with statins, antihypertensive drugs, tighter control of glucose amongst diabetics, and the guidelines of 2017 suggest a single antiplatelet agent. Now, when we look at trials that have been conducted in the past, we can think about the two aspects of interest. One is to lower the ischemic risk of a patient, and the other is to minimize the price we pay in terms of keeping the bleeding risk as low as possible. And on the far left, you can see the trials that have evaluated either single antiplatelet agents or more potent antiplatelet agents compared to others. And really, this body of evidence coming from the Antiplatelet Trialist Collaboration meta-analysis is what informs the single antiplatelet therapy recommendation for patients with PAD. In the earlier years, the mid-2000s, we conducted a trial called the WAVE trial, where we evaluated full-dose anticoagulation with warfarin, INR 2 to 3, together with antiplatelet therapy. And in the WAVE trial, we observed no reduction in ischemic events, either cardiovascular or limb, and a 3.5-fold excess risk of life-threatening bleeds, including fatal bleeding. So the WAVE trial really put the brakes on the use of long-term warfarin, INR 2 to 3, in patients with PAD. And in fact, it was the excess bleeding that negated the risk in terms of lowering the ischemic risk due to fatal bleeds, essentially bleeds causing cardiovascular death. Now, we come to the middle of the slide, and really it has been the VOYAGER trial, and now most recently the VOYAGER trial, COMPASS and VOYAGER together, that have evaluated low-dose anticoagulation with DOACs, in particular rivaroxaban, at 1/4 of a full dose, together with aspirin, in patients with PAD. And these trials together, now 2 large trials, have really solidified the evidence that this combination therapy hits a sweet spot of minimizing ischemic risk and minimizing bleeding risk. And you may have heard of this already today, but essentially we're trying to target preventing platelets from becoming activated and preventing thrombin generation. So we call this dual pathway inhibition or dual pathway therapy. The COMPASS trial was a relatively simple design, 2 experimental arms, one with Riva 2.5 BID with aspirin, the second arm with Rivaroxaban 5 milligrams BID, no aspirin, and the comparator arm or control arm was a single aspirin once a day. We enrolled patients with coronary artery disease or peripheral artery disease into the trial. The trial was event-driven. We expect the follow-up would be between 3 to 4 years, but as many of you know, the trial was stopped early due to overwhelming benefit in favor of the low-dose rivaroxaban aspirin combination. Now, when we look closely at the PAD patients enrolled in total, 7,470 patients, about 25% of the 27,000 patients in the overall COMPASS trial, the patients were eligible to be classified as PAD if they had symptomatic PAD of the lower extremity, a history of carotid artery disease, which could be a carotid stenosis more than 50% that was asymptomatic, or prior carotid endarterectomy, or patients with asymptomatic PAD, that is coronary disease with a low ankle brachial index at baseline. This slide shows the main results combining the MACE or male, including all major amputation outcomes together. And you can see the incidence of this combination of events is significantly lower in the Riva plus aspirin group compared to the aspirin alone group. And this translates into a 31% relative risk reduction, highly significant, and a very favorable number needed to treat. This shows the Kaplan-Meier curves of that 31% risk reduction. You can see the black line representing Riva and aspirin, the red line aspirin alone. These curves diverge early and continue to diverge over the course of the follow-up. What about bleeding? That's always an important question. We know when we intensify antithrombotic therapy, we will likely expect more bleeding. Our primary outcome was a definition called modified major ISTH bleeding, essentially any bleed that led a patient to see a physician. There was a 1.7-fold increase in this type of bleeding with the low-dose Riva plus aspirin compared to aspirin alone. Now, importantly, when we looked at fatal bleeds or non-fatal bleeds into a critical organ, including intracranial hemorrhage or other critical organ bleeds, we did not observe any excess in the Riva and aspirin arm. So essentially, 2/3 of these bleeds over here were gastrointestinal in nature, and the majority were treatable bleeds. So that's reassuring. When we look at how the different types of PAD patients benefited in comparison to the overall population, it's really reassuring to see very consistent risk reductions across all subgroups of patients with PAD. This really adds confidence to the believability of this result. Now, in patients with PAD, we performed a subsequent analysis where we showed that the major adverse limb event, including acute limb ischemia and amputation, was significantly lowered in the Riva aspirin treated patients compared to aspirin alone. But then we also said, what about the prognosis after Mayo in these 2 treatment groups? And you can see that just by looking at the height of the red bar in the aspirin-only treated patients, that if a patient were on aspirin, and developed a major adverse limb event, thereafter, the risk of death, total amputation, or a combination of these events was substantially higher compared to those patients who may have been on Riva and aspirin at the time they developed their major adverse limb event. So it's possible that the Riva-aspirin combination that prevents MALE also, if MALE does occur, is associated with a less severe type of major adverse limb event. Now, which PAD patient should be treated? I'm often asked that question. People say, well, should we treat every single patient with PAD with this new combination therapy? And so we've done additional risk stratification analyses in our high-risk COMPASS population to identify the highest risk population. And in this analysis, we looked at patients in two ways to define high risk. And in two independent ways, the analyses pointed to the same types of patients. Those patients with polyvascular disease have a number needed to treat or absolute risk reduction, which is 6% or 60 events prevented per 1,000 patients treated. Patients with a history of heart failure, absolute risk reduction is 4.4%. Low eGFR, again, 3.6% absolute risk reduction. Diabetes, 3.1% absolute risk reduction. And any one of these high-risk features is associated with 3.3% absolute risk reduction. So these are pretty simple criteria to keep in mind. And again, assessing a vascular patient, just determining polyvascular, heart failure history, low eGFR, or diabetes. Without too much thinking, these patients will certainly benefit with quite a substantial absolute risk reduction with the Riva and aspirin. Now, most recently, Eric Kaplovich and the COMPASS group, we published a paper in JAMA Cardiology saying within PAD patients who are the highest risk by their limb presentation, and we observed that patients with a prior amputation, and shown in the red line, and patients with severe symptoms such as rest pain or non-healing ischemic ulcers, as well as patients with a prior history of revascularization, all have an incidence risk over 2.5 years of more than 10%. So that group of patients, defined by their PAD limb history, is a high-risk group of patients. We then combine those clinical criteria of polyvascular disease, diabetes, heart failure, low eGFR, together with the limb presentations, and we define the incidence risk. And certainly, no surprise, if a patient has both one of the high-risk comorbid factors plus a high-risk limb presentation, they'll be the highest risk patient of all. When we looked at the prevention of MACE, MALE, and major amputation across these subgroups of patients, I'll just draw your attention to the gray bars versus the yellow bars. And the gray bars connote the absolute risk reduction. And so patients who have a high risk feature by their limb, by a risk factor, or by both a limb and a risk factor have significant absolute risk reductions with Riva and aspirin. And down here in yellow is the severe types of bleed, fatal or critical organ bleeding. And essentially you can just subtract the bleeding from the absolute risk reduction here and come up with what the net clinical benefit of using aspirin and rivaroxaban will be for the patient. You can see it's very favorable when we compare these highest risk patients in terms of their absolute risk reduction with the therapy and the small number of bleeds caused by this intensified therapy. On the other hand, if there are no high risk features in our PAD patients, we have a harder decision to make because we have an absolute risk reduction of 1% and we have caused 0.6% of bleed. So it's a closer, narrow margin for deciding if treatment's beneficial in there. In the VOYAGER trial, the most recent large trial, the same combination of low-dose rivaroxaban and aspirin was compared to aspirin alone in PAD patients. The difference being these patients had just undergone infrainguinal revascularization. In total, about 6,500 patients from centers worldwide were randomized to one or two groups. Now, there were a couple differences again. Patients could be revascularized either endovascularly with an angioplasty stent procedure or surgically. And as many of you know, with angioplasty and stent procedures, clinicians often like to use dual antiplatelet therapy. So patients entered in this trial could be stratified based on endovascular versus surgical therapy and clopidogrel use versus not. So two stratifications in this trial. This slide shows the overall comparison of the low-dose Riva and aspirin in purple compared to aspirin alone over the course of 3 years. And you can see that the Rivaroxaban and aspirin combination was associated with about a 15% relative risk reduction, which was highly significant. And this translates into an absolute risk reduction of 2.6% or NNT of 39 after 3 years of treatment. And I'll also point out that the curves again diverge pretty early within 3 months of starting this therapy. So overall, a positive trial. I'll point out that the primary outcome was similar to the COMPASS MACE or male. In particular, it included acute limb ischemia, major amputation, or MI, ischemic stroke, and CV death. When we look at the components of the primary to look at the impact on individual components, it's really something to see that it's acute limb ischemia that's reduced the most, of 31% risk reduction in acute limb ischemia. The reason acute limb ischemia is so high in event number is patients who are immediately followed post-revascularization. That's their highest risk because the limb is just being revascularized. If they thrombose the revascularized territory, boom, they'll develop acute limb ischemia. So in the first year after such a procedure, this is the most common event. I showed you these are events we definitely want to prevent, and it was clear in the VOYAGER trial that this was significantly reduced. What about the safety profile of Riva and aspirin? Slightly different definition of major bleeding was used in a revascularization trial. In this trial, the TIMI major definition of bleeding was used. That's a more kind of severe types of bleeds are classified as TIMI major bleeds. So when we look at the hazard ratio, we see an increased risk of major bleeding that did not reach conventional levels of statistical significance. However, if we go to the far right of the slide and use the ISTH major bleeding definition, we do see an increased risk of major bleeds that is significant with the Riva aspirin therapy. So very similar to COMPASS. Now, if we move to the center of the slide and we look for those most severe types of bleeds, we do not see an increase in intracranial hemorrhage or fatal hemorrhage or the combination of these bleeds. So again, reassuring that the bleeds that are associated with Riva and aspirin are typically GI bleed and source and treatable bleeds. So overall, we're getting a flavor again of a net clinical benefit of this therapy in the revascularized PAD population. Now, the question of does clopidogrel change the impact of excuse me, Riva and aspirin? We do not see any change in the hazard ratio in patients who were receiving clopidogrel versus those who were not, and the p-value for interaction comparing these strata is not significant. So essentially, it makes no difference on the primary outcome if patients who receive Riva and aspirin compared to aspirin alone were also placed on clopidogrel versus not. So this is important. When we look at the impact of this therapy in the surgically revascularized group versus the endovasc group, there's no difference in the treatment effect. The p-value for interaction is not significant. And as I showed you, no interaction whether or not clopidogrel was used. So when we put these trials side by side, we can see that Riva and aspirin are in combination is an effective combination in the recently revascularized PAD patient. as well as the stable outpatient PAD type of patient enrolled into COMPASS. When we come back to this slide of where do we stand in 2020, we've now shaded in the VOYAGER trial to really show that this is the sweet spot at present where high-risk PAD patients will benefit with this combination therapy, and it's the best evidence we have to date, 2 large independent trials. So to summarize, Riva 2.5 milligrams twice daily in aspirin compared to aspirin alone reduces this array of events, the MACE and the male events. Acute limb ischemia is an important one to reduce. It's particularly high incidence after lower extremity revasc, and it was significantly reduced by this combination. And the benefit of the Riva aspirin appears early with those curves diverging and persists over time and is consistent regardless of the type of revasc and the use of Clopidogrel. So now I'm going to go to the polling questions. So hopefully this will work. And the question is, should warfarin be used in the regular management of stable PAD patients? Yes or no? And Jeff, I guess I just wait.
Go to the next slide, Sonia. You'll see the answers.
Give you a lot of time to vote. Don't all vote at once.
I know. Guys, take your time. Hope
I didn't put anyone to sleep.
Okay, I'll answer that. I'll give it a no.
You're right. So based on the WAVE trial, where we saw excess life-threatening bleeding, I kind of put the brakes on this therapy. Somebody's asking a question, Jeff. Maybe I'll
to present the resend the thrombosis keyword. It was thrombosis.
Okay. So maybe that'll help for our next question.
Right.
And this question is, which PAD patients can benefit from the use of low-dose Riva, tiny typo, and aspirin? And the groups are prior revasc of the lower extremity, prior foot or limb amputation, carotid stenosis more than 50%, or all of the above. And I'll go to the next slide. See if our voting goes up.
I'm sorry, Sonia. It looks like the system's not working.
Okay, no problem.
Okay.
I'll just talk my way through it. So all of the above is the correct answer. So you've got that wide array of type of PAD patient with COMPASS also including carotid artery disease, and that's a substantial number of patients out there. So keep that in mind when you see such a patient. And the final question is, Clopidogrel should be added to PAD patients who have undergone endovascular revasc who are being treated with the Riva and aspirin. Yes or no? And if I jump ahead to the answer panel, the answer is no. In the VOYAGER trial, there was no added benefit by adding Clopidogrel to the Riva and aspirin, even in the endovascular patients who could have received angioplasty and a stent. So I think it's time for questions.
That's great. Sonia, that was great. We have a great question, actually. So an anonymous attendee said, fantastic presentation, thank you. Just wondering if there are any past or present studies around Riva and low-dose ASA that are independent of pharma, and they're concerned about perceived biases due to their involvement. They wanted you to comment on both of those questions.
Yeah, that's a good question. And to my knowledge, there are no independent low-dose Riva aspirin studies. Both of these were funded by Bayer, as was the trial that informed this one, which was the Atlas II trial in acute coronary syndrome. So that, there is always the concern about that. I will say, being involved in in both trials, and from our home institution in Hamilton with the COMPASS trial, it is very arm's length. We run the trial, we get unblinded before the company knows the results, etc. So, I mean, to do these large trials, you can't really do them, unfortunately, with CIHR, heart and stroke funding. You can. The WAVE trial was done in that way with warfarin, but it's really, really tough. So the best I can do is reassure you, having been in the center node of the COMPASS trial, that things were, run as best we could at arm's length.
Okay. The next question is a great question, applies to primary care so much. What's your feeling about the use of SGLT2s in type 2 diabetic patients with non-surgical distal PAD?
Yeah, that's a good question. And the lead-in is because in the CANVAS trial, there was a signal of increased risk of amputation with patients on campagliflozin. And so after that trial, people were worried and thinking about what happened. If you look deeply into the CANVAS trial, at some of their buried data, you can see that acute limb ischemia seems to be up and kind of predate the amputation. So then there were lots of hypotheses. Was it because that drug actually is intravascularly sucking fluid out and, diuresing the patient, and then they become prothrombotic? It's really difficult to know. Then we wait and we see, the drug Giardians or empagliflozin results. And in that trial, there was no signal of acute limb ischemia / excess amputation. And now across multiple trials with dapagliflozin, again, that hasn't been seen. So I use SGLT2 inhibitors in patients with PAD. I typically will choose empagliflozin over canagliflozin. I'm not sure if what happened in CANVAS was a play of chance or real, but I'll choose one or the other.
Okay. Is there any group of patients, apart from AFib patients, that you would recommend full dose anticoagulation plus or minus antiplatelets?
Okay, with PAD, I'm assuming.
Yeah.
That's a good question, and many of you who see these patients will know one of the toughest treatment decisions is after the patient has been admitted to hospital with acute limb ischemia, gone first on IV heparin, gone to the OR, revascularized, comes out on IV heparin, and then at least in our center, our surgeon will say, okay, now thrombo, decide. Or the surgeons themselves will say the patient has to be on warfarin. So in patients with acute limb ischemia, in whom, I looked through the procedures, was an embolectomy occurred and they fished out a huge thrombus? Do they have one single conduit their whole leg is being perfused by that cannot go down no matter what? In those severe patients, we often will use warfarin with the kind of asterisk being short-term warfarin. So we try and see them at 3 or 6 months after that and make a decision to step them down off that therapy. Having said that, I've had some failures when I've stepped down and the patient, does recur. So I do have a small percentage of patients who are on long-term full-dose warfarin, sometimes together with an antiplatelet. It all depends on their history of being tried on multiple ones, and if they've failed on lower-dose combinations, I will go up in intensity.
We have a great question on the treatment of PAD. Should a statin be added to aspirin and or rivaroxaban for PAD, or should you use aspirin and or riva alone?
Great question. And, it's targeting a couple different aspects of the pathway of, statin prevention of atherosclerosis / inflammation, and aspirin riva preventing, atherothrombosis and embolization of that thrombus. So kind of like two different components of the pathology in PAD. So they should be on, what most guidelines are, what point towards is smoking cessation, statin, control blood pressure, control glucose, and add your antiplatelet or antithrombotic combination. So it's added.
Okay, we have another question that we get asked very often. If we were to use 80 milligrams of ASA, could we replicate this trial or these trials?
We think so, and we recommend it. The 100 milligrams came from the company because they make it at 100 and it's used in Europe. But if you look at the antiplatelet trialist collaboration meta-analysis, they have a really nice analysis on the dose of antiplatelet, and it appears that there's good efficacy of the antiplatelet agent aspirin down to 75 milligrams of aspirin, and that dose is associated with the lowest bleeding risk. So we do advocate it at the 81. It should be considered equivalent. We always get asked about aspirin resistance. We still don't have good data to know either way. So this is a recommendation.
Okay, this one's interesting. The patient has AF, they're on full dose NOAC, and they get diagnosed with PAD. What do you suggest?
Yeah, those are tough. We treat to the AFib with the appropriate dose.
So you don't add aspirin?
Depends, usually not. If they're hot, like acutely with a STEMI or acute limb, maybe short term add the aspirin, but then eventually take it away. Yeah, so we do treat to the AFib. Will there be a trial in the future in AFib patients with this low dose combination and aspirin? A lot of people have called for such a trial. It would be interesting, but it's not underway to my knowledge.
We have a couple of attendees who asked about the use of clopidogrel and PAD, or the use of clopidogrel instead of ASA with Riva. What's your feeling about that?
Yeah. So, you know, from the Capri trial days, which was a long time ago, like 25 years ago, clopidogrel was shown to be slightly more beneficial than aspirin in patients with vascular disease, including PAD. So I often describe it like aspirin's like if you're driving a Ford, and Plavix is like the Cadillac. So you get a bit of benefit, a better drive. In 2020, I think that if your patient with PAD is on the low risk side of things, so just simply intermittent claudication, no history of revascularization, no concomitant CAD, you could probably get by with a single antiplatelet agent, and Plavix would be just fine, or clopidogrel would be just fine. And with respect to using Riva with clopidogrel, I have a few patients with aspirin allergies, and I replace the aspirin with clopidogrel.
Okay. We have two attendees who asked a similar question. If you have a patient on low-dose Riva and ASA for PAD, and they're admitted for acute illness and they're requiring DVT prophylaxis, would you increase the Riva to 10 milligrams based on Magellan, or what would you do with this patient? Yeah. Similarly, the other attendee asked, would you hold the Riva and keep ASA and low molecular weight heparin?
Right. Well, in COMPASS, we did observe a reduction in venous thromboembolism with the low-dose Riva aspirin. So I think it's a reasonable VTE Pro combination. So if you had the PAD patient admitted with pneumonia already on the Riva aspirin, I wouldn't change it.
Okay, that makes it simple. Thank you. Are there any weight-based analysis with the dosage of antiplatelet or DOAC for cardiovascular disease?
In this analysis, I think we've done a subgroup analysis by body mass index, but maybe just with a couple of cutoffs. We didn't really have anyone with, not many people greater than 100 kilograms. So at this point in time, from the subgroup analysis that has been done, it appears like the combination works in both, lower and higher BMI, but we don't have a lot of data points about the 100.
Okay, thank you, Sonia. That seems to be all the questions. That was absolutely great. Thank you so much, because it seems to change in primary care what we're doing. We're certainly seeming to use a COMPASS regimen in our PAD patients now, which is very cool.
Yeah, it's exciting for the field because, like, forever we just had aspirin, maybe clopidogrel, then warfarin was a bust, and we know they're just so high risk. The other last point I'd say is I talked about statins. There's also great data with PCSK9 inhibitors. So if you're doing like the Cadillac treatment in PAD and the patient is statin intolerant or LDL still not lowered with a good dose of a statin, then using a PCSK9 inhibitor also reduces acute limb ischemia.
Right, we saw that in Fourier. It was quite impressive, eh? Yeah, that's great. Okay, thank you so much.
Yeah, thanks everyone.
All right, thank you everyone for attending, and thank you for all the presenters. Great presentations, great evening. I'd ask all of you, if you complete your evaluation, the link is on the screen right now. The link will also be emailed to all of you. We thank you for all attending this evening, and we really hope you enjoyed it. The recording will be available on the virtual platform and also on the Thrombosis Canada website. So thank you everybody, stay safe, thank you for joining us, and enjoy the rest of your evening.